Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I am here with my amazing, I can't think of another adjective because they're just so
Artistic,
amazing.
You are
artistic.
stumbling way too much.
Y'all are definitely more artistic than I am. My my amazing artistic co-host, Dr. Carrie Bedient from Fertility Center of Las Vegas,
Hi.
and Dr. Abby Eblen from Nashville Fertility Center.
Hi.
How are you guys doing?
Doing great. Carrie
I'm,
sounds like she's struggling though.
I need inspiration, guys.
Are you
Apparently,
are you
apparently you are
frustrated?
obligated. Yeah, well, so you're obligated to feed your family every day.
I know. Doesn't that suck?
And it turns
Not
out you can
fair.
go to jail if you don't. And I look good in orange, but not orange jumpsuits. And so I found some of the quick things that I can do after clinic, because most of the time I'm getting home and like dinner needs to be served really pretty quickly
Immediately.
here,
Yeah.
immediately, if not sooner. And so I found like the Costco immediate chicken things like the Kevin's Paleo, where you just throw
Mhm.
it in the skillet and heat it up and also put
Yeah.
like rice and a vegetable, something like that. And I found Sur La Table has these jars of simmer
Ooh.
sauces. Like there's a coq au vin, there's a Meyer lemon one, like there's a couple
Ooh.
others. So I've used those because all you have to do is dump it in and shove it in the oven.
Nice. That
Um,
works.
but I need inspiration because I don't
So,
want to go to jail.
being from Texas, you can make anything a taco and it gets more fun.
Yeah.
All right.
But seriously, like we have, and granted, we probably have a lot of like more pre-made things that go straight into a taco, but hey, you're on the border too. So, like our grocery store will have
I'm
like
not on the border. Can I make tacos?
carnita, but you can. So like you can get like pre-made carnita things or
Oh,
other
Uh-huh.
type of it just pick a random type of pre-done meat,
yeah.
Uh-huh.
stick it in a taco, add some cilantro, add
Okay.
some queso fresco that you crumble up, and literally in 5 minutes you got a meal.
One of you don't like cilantro. If I remember correctly, Carrie, you don't like cilantro. Is that
Oh
right?
no, I love
Oh, do
cilantro.
you? Okay. Yeah, I do
I
too.
have no
Yeah.
objections to most spices, except for licorice stuff and anise, which is just gross.
So, in case you've missed these other two, Whole Foods and Sam's also have like pre-prepared stuff or stuff for families too. So you can
Okay.
look at those. But what I've done for many years, because actually a reproductive endocrinologist in Atlanta who's much older than me, actually before pre-prepared meals were available, she actually hired a cook from the country club to come in her kitchen and prepare meals and either freeze them or put them in the refrigerator. So all she did is when she got home from work, she pulled them out and heated them up. Well, you don't have to do that anymore because you got Green Chef, Hello Fresh, Martha Stewart has something. So
Mhm.
we've done those and they do require like maybe 30 minutes of work, but the huge advantage is you don't have to go to the grocery store. You don't have to buy the meat. You don't have to buy like an onion where you only use a quarter of it. And so it really it speeds it up because you got the recipe right there. You got all the stuff you need. You just have to throw it together and do it. So we've done those for a long time because
I,
just you're right, it's too hard to
I do
come
say
up with
take
something every
advantage
day.
of the things at the grocery store now that are like pre-chopped and stuff like that.
Yeah.
Like, why chop an onion anymore? I mean,
Yeah.
unless there's just you need to teach somebody how to chop an onion, like don't like
Yeah.
that's 2.5 minutes out of your life you could be doing something else.
Yeah. Well, it's
And
kind of
my
finding the
other
balance between wanting to have everything pre-made, but also not wanting to be wasteful of either ingredients or
yeah,
money. And like being balanced is absolutely no fun.
yeah. Well, and the other thing too, so Green Chef has all that, and they'll give you all the new nutritional information and all that. And I mean, all the other pre-prepared ones do too. But the other one, there's a company, and I think it's a chain called Super Suppers. Have you ever heard of that?
Mm-mm.
No.
There's one locally around here, and so like a lot of times when I have somebody who's needs food for some reason, lost somebody or some extenuating circumstance, you can buy them and they're frozen meals. And then it gives you all the directions on how to thaw them. And some of them are like casseroles, but some of them are main entrees. You can get sides, but they're all fixed by somebody there and frozen. And every month, if you look online, every month it will tell you like what their meals are and what you can get. And they're really good, really, really good.
Okay.
Interesting.
Duly noted. I will look
Super
up
suppers.
super suppers. Okay.
Yes.
All right. Thank you for rescuing me and for hopefully not sending me to jail because
You
I
need to
think
feed your family.
the balance of the podcast would probably be disrupted
It
if there
would.
were only two
Yeah.
of you
Hey,
guys.
two out
So
of three. It just wouldn't be the same without you, Carrie.
thank you for
Or
hearing.
without you, Susan, either. So you're
Thank
right.
you.
We're a
I agree.
balance.
I don't look good in orange in any circumstance. So
All
Eh,
we're
bright orange, I'd be okay, but yeah, I don't really want to go to jail. That's
all
no jail
right.
for me, thanks.
Let's do a question. So here's our question. Thanks so much for your podcast. I wish I had discovered it before diving into IVF. Well, thank you so much for listening. I have questions about day 7 embryos. I'm 37, wanting my second child, unexplained infertility, and an 18-month son from IVF. During my initial retrieval in November of 2021, we ended up with 5 PGT normal embryos. The first transfer day 5 was unsuccessful, was a chemical. Second transfer day 6 resulted in my son. Starting to try for my second child, my doctor informed me that the rest of my embryos were all day 7 and had much lower implantation rate. So he is recommending transferring 2, which we did in July, and it was unsuccessful. We have one day 7 embryo left. It's difficult to find information on day 7 embryos. Can you provide further insight? So I think this is the blessing and the curse of our technology getting good enough
Hmm.
that a lot of us
Yeah.
are testing and biopsying day 7 embryos. I think we all probably have a little bit of a perspective on this. What do you ladies do in this situation?
Well, day sevens just are not as good, at least in our center. And I'm sure every center looks at their own data, but based on our data, there's about a 20% drop in pregnancy rates compared to baseline in patients that use day sevens. And nobody really knows why. I think a lot of it has to do just with the fact that something other than the actual chromosomes may be problematic with the embryo. If it took the embryo 7 days to get to that stage of development, that means it's slower growing, and there's just something that may not be working quite right with the machinery. And so we definitely transfer day 7 embryos, and we have pregnancies from those. But just all things being equal, we would prefer a day 5. Day 6s are pretty close, but day 7s we would prefer not to transfer those. But I mean, we do if we need to, if that's all we've got left.
Carrie?
So I kind of think of this the same way that I do grading, in that if you transfer a C grade embryo, it's not like you're going to get a C student for a kid. Um, it's just that you're less likely to meet with success. And so I don't think you have any harm, especially if you're just going for one more kid. I don't think you're going to do any harm by transferring, because it's either it's going to work and you're going to be happy. It's not going to work and you're going to have to go do another retrieval. You're going to have a miscarriage, which is going to suck while not working and probably send you back to another retrieval. But none of those things tend to be life-threatening. They are just really obnoxious and in varying stages of horrible, depending on where you are in your personal journey. And so, I have a patient of mine where we actually used donor eggs, and we got, out of the 5 frozen eggs, we got 4 embryos, 2 day 5s and 2 day 7s. The 2 day 5s were a biochemical and a miscarriage, and the 2 day 7s are beautiful children. And so, like, if it works, it works. And so it has lower success rates. And so instead of having a PGT tested embryo that I would normally say is, roughly 70% success rate in our center, I'm going to be telling you more like, we're probably looking 40-50. There's probably a higher than 5% chance that it's not going to survive the thaw. So just be mentally prepared for those things. But, if you get the kid, you get the kid.
So one thing we do at TFC is we really look and see kind of the stage of the embryo. A lot of those day 7 embryos tend to be hatched instead of expanded or hatching. And so if we have embryos that are already hatched, we do add an additional day of progesterone exposure. And it seems to have improved our success rates on some of those day 7 embryos.
Hmm.
So that's something to think about. The other thing is also don't necessarily chuck the failed embryo transfer of 2 day 7 embryos to the fact that they were necessarily day 7 embryos. I would sit down with your REI and say, hey, is there any other testing? Make sure you've had your uterine cavity evaluated. Make sure your thyroid's where it needs to be, your prolactin's where it needs to be. All of those housekeeping items, we want to make sure we're not losing the forest for the trees and missing something that's obvious because maybe it just wasn't done because it's like, oh, it's just another embryo transfer trying to, get baby number 2. So, all righty. Well, today we are going to talk about what to expect after you have your egg retrieval. And we're really excited about this subject. As many of you know, we have a book coming out in fall of 25, all about IVF, and we have a whole chapter dedicated to this. And so, to kind of give you a little preview of what we're thinking, we're going to talk about what to expect after you have your egg retrieval. So, we're going to start immediately after egg retrieval. So we are rolling back from the operating room into your post-op room. What do we expect from somebody immediate post-operatively after an egg retrieval?
Well, you're groggy for one thing. So you're just waking up from anesthesia. You may be crampy, probably are crampy. A lot of this you may not remember for the first 30 minutes to an hour, but as you slowly start to come out of anesthesia, you're going to start noticing that mainly cramping and just feeling just really kind of just, things are a little blurry. You don't remember quite what happened. You may find yourself asking the same question over and over again, or your husband or partner may go, okay, you just asked that question because sometimes people are given medicine that makes them forget a little bit. Um, as you stay there for a little longer, your bladder gets full, and eventually we send you off to the bathroom. But those are kind of the immediate things that you experience right if you come out from anesthesia, I think.
Mm-hmm. We typically talk to you after you're out of anesthesia, and we try and balance it to a time when we think that you're actually going to remember the conversation. Although admittedly, I have had patients, and I have learned over the years, I always tell people before the procedure, I am going to talk to you after the procedure. You may or may not remember it. And because I have had patients come back to me just spitting mad. Why didn't you come talk to me? And I'm like, oh, honey, we talked for 20 minutes and we solved the problems of the world in those 20 minutes. And it's unfortunate that she doesn't remember it, but such is anesthesia. And so we make sure of a couple things. Number one, oftentimes your partner is back there while we are talking to you. So you've got a second pair of ears. And I try to always tell the partner, hey, she may or may not remember anything we're saying. So just be prepared for that. And number two, there's always a follow-up appointment at some point where we go through everything. Now, sometimes that can be a couple weeks later because we're trying to wait for more information to come in where we can actually have something reasonable to tell you. But yeah, if information is important, it's rare that we're just saying it once.
Yep. And another thing to know is when you're coming out of anesthesia, um, sometimes it's the first time you've let your guard down in a while. And what I mean by that is it is common to maybe be a little more emotional than you normally are to your friends and family, because we do see that oftentimes people who are coming out of anesthesia, they might be a little more tearful or anxious than they normally are. And these are all normal things that we're used to experiencing. So if you find yourself a little more on edge as you're coming out of anesthesia, know that we're here for you. We're going to take care of you. We're going to make sure that everything's going well. So, how much pain should somebody expect coming out of an egg retrieval? And does that vary from patient to patient?
I think there's a big variation from patient to patient because, we all experience lots of emotions differently. We also experience kind of level of pain differently. And like Susan said, I think more emotional patients tend to be more, kind of experience their pain a little bit more. But, part of what we do when you come out is, and I always say patient to patients when we're talking about IVF, that, this is a surgical procedure, just like any other surgical procedure. And so we do worry about problems that could happen. And, that's because we like to, or at least prepare for worst case scenario. We don't expect worst case scenario. 99.999% of the time, patients do fine, but there's lots of big blood vessels in there that we have to get past. There's bowel, there's bladder, those sorts of things. And so really the purpose of your first about hour and a half that you're with us before you go home is to look at blood pressure and pulse and vital signs and just make sure that you're feeling as you should. Your pain should get a little bit better, and certainly we can treat you with some narcotics while you're there. But as you start to get kind of more awake, pain tends to get better, and sometimes too, as I mentioned before, the bladder can be really full. And so a lot of times if we let you empty the bladder, that kind of helps a little bit with your discomfort. But I would say, just in one sentence, just a kind of mild crampy pain is pretty normal.
Heat and ibuprofen, all the same things you would do for a nasty period, they are all helpful here. I always tell people kind of sleep with a little bit of an incline, so you've got some pillows stacked behind you. There's always some free fluid after a procedure that is normal, that's expected. And if it is staying down low, that means it at least is not tracking up and hanging out under your diaphragm, right under your lungs, which can sometimes make it more obnoxious to take a really deep breath and feel like you're kind of short of breath just because you can't expand fully. And so sleeping on an incline can be really helpful. Some people are really anxious about the nausea that they've had after anesthesia in the past. One thing to know about the type of anesthesia we use, number one, these procedures are pretty short. Number two, most of us rely pretty heavily on propofol, which is great because
Mhm.
it's a medication that one of its nicknames is milk of amnesia. And so it makes you comfortable as you're going through it. It helps you, be out and be asleep. But the positive side of it is that most people don't get really nauseated as a result of it. Now, you
Mhm.
can have nausea if additional medications are used, especially narcotics. In some cases, that is very appropriate. In other cases, we don't need to. That's the anesthesiologist who's watching that during your procedures to kind of figure out, okay, where are you? Are you comfortable? Do you need something more? But a lot of people don't really struggle with the nausea post-operatively
Mm-mm. No, really
because,
don't.
yeah, because of what we use, and
We do
we
pretty
we
good.
are very intentional about that.
All right. So after you've kind of recovered, you're probably going to be wheeled down in a wheelchair to the car that you're leaving in because that's just good hospital policy. And we want to make sure no one's going to trip and fall on their way out, especially after anesthesia. Now, anything that our listeners should know about the
The
ride that
car,
they
the
choose
car
to
that
get
you're leaving
home?
in. Yeah, so this is really more applicable, I think, to patients who don't have a partner, maybe doing egg freezing, but you really want to have somebody that you trust that's going to drive you home. And so for a
Or
while
if both
there,
you and your partner are having procedures
yeah,
together.
then you need somebody who has not had narcotics recently that will be driving you home. And you also want somebody that you know and trust. And so, well, the reason we laugh and say that is because I'm sure all of us, even over the past year, have had maybe one patient who was planning on taking an Uber or a Lyft on the way home. We cannot let you do that. You cannot go home with a stranger when you've just come out of surgery and you're still under the effects of anesthesia. So make sure it's somebody you know and you trust.
Do not put your drunk friend in an Uber. And
Right.
we do not put our drunk friends in Ubers.
Good
You're
point.
you're pretty much drunk after anesthesia, and so we will make you stay with us longer. We will have somebody else drive you home. Like,
Yeah.
yeah.
This is an important, important, important thing. Okay.
The
So,
other thing to know about the drive home itself, especially if you do not have great roads in your area or if there's a lot of speed bumps,
Oh,
tell your driver to go real slow over those speed bumps because that fluid that I mentioned earlier, it
uh,
won't cause harm generally, but it does not feel good jostling around in
and
there.
big ovaries too.
And you got big ovaries too. And so go slowly over the speed bumps.
all right. So, say you get home, around lunchtime or a little bit after lunchtime. Any advice for what you should eat, what you shouldn't eat, what your activity that afternoon should be?
So I think eating is kind of anytime you come out from anesthesia, you never know how somebody's going to respond to it, particularly if it's been the first time you're under anesthesia. But you really want to start out slowly. You don't want anything real greasy or real spicy, anything that could, you don't want to eat those like tacos, that Susan and Carrie were talking about earlier. You don't want to eat that for lunch. You want to eat just something that's real bland. Chicken soup is great for a reason. It's real bland. Things like that. Bananas, crackers. Start out slowly before you put a big meal in your body.
And part of that is because if you're going to throw up, eat something that you're going to not object to if you do throw up. And granted, it's pretty rare that people actually do, but
It is.
that's the guiding principle after anesthesia is don't eat anything that you would object to the second time.
I think an important thing to think about is number one, hydration is the most important, okay? Because we really want to flush all of that anesthesia medicine out of your system and really make sure that you have a good balance of fluids within yourself and eat because you're hungry. So a lot of times the people who most often get sick, in my opinion, other than those people who just don't tolerate anything well, it are people who go and they're like, oh my goodness, it's time for me to eat. I'm not hungry, but I'm going to eat anyway. like take a few bites, get a little something in your stomach, but don't feel like just because it's noon that you have to eat. Like
Hmm.
I said, being hydrated is the most important thing. The afternoon, that's a good time to just bum out, watch a movie, don't plan
Sleep.
on sleep, don't plan on making any major decisions. Ideal if you don't have to do any major travel that day. I know some people have to drive or fly to wherever home is because of circumstances, but if you can give yourself a rest that day and that
Hmm.
evening, it's a good thing to do.
My standard instructions for people post anesthesia of really any variety, but most often retrievals, is no driving, no working today, no major life decisions, no taking care of human beings, large or small, no drinking, no gambling, and no dancing on tables, no pet stores. But if you do go to a pet store and you get a new puppy, a
Stores.
new kitten, you have to bring it back to the clinic for
Uh,
us to cuddle too. I've only had that once, but he was the cutest puppy ever. I totally pulled doctor's privilege and I hogged that puppy so much. And then the other one is no unsupervised online shopping post anesthesia.
Mm,
Yeah.
that
All of
sounds
those things come from real life experiences of patients who have done them and come back to us. Some of them really quite mad because all these Amazon boxes showed up on their doorstep. And so those are my standard instructions.
those are good ones. Those are good ones. All right.
well, and more seriously, some of the instructions I would say, if anything happens outside what you think should happen. So if you feel really dizzy, lightheaded, severe abdominal pain, vomiting, fevers, those are not normal things. So we definitely want to get
Chest
phone calls
pain,
about
trouble
that.
breathing.
Trouble
Yeah.
breathing, yeah, any of those
Yeah.
things, those are not normal. So call us.
Right. And know that there is somebody, even if it's after hours, if you call your physician's office, there's going to be a phone number that they're going to say, if this is a medical emergency, you can call this number to get a hold of somebody, and somebody in the practice will be able to speak with you. So they'll be able to kind of help guide you through this. And I think that's a really important thing to do, because sometimes these things that you may be experiencing may be along the realm of normal, but they're abnormal for you. Okay. And we
Hmm.
can help figure that out. Or we can be like, ooh, this is one of those things that we really need you to go into the emergency room to
Yeah.
be evaluated. Now, with that being said, if your reproductive endocrinologist says, I think you need to go to the ER to be evaluated, this is not the time for negotiation.
Hmm. Yes,
Yes.
that's
Agreed.
right.
Agreed.
All right. Because your safety is always our number one priority.
Now, we do want you to get up and walk and move after your
Mhm.
retrieval. And so you do not need to be glued to your bed. Now, of course, there's the common sense component of this, in that you will be post anesthesia. And, now is not the time to go run a marathon.
No
Um,
Orange Theory.
no Orange Theory, no
Hit
getting back on
exercises.
your bike, nothing, none of that stuff. But we do want you to be up and moving. Plan to go slow. Do it around your house, take a walk around the block. As you get further and further out from your retrieval, you can start extending this activity. But we usually tell people until you get your next period, no gym, no
Hmm.
sex, no major vigorous activity. And the reason for all of those is because your ovaries are still big and they're still kind of fragile. We have poked them quite a few times, and we don't want to dislodge any blood clots to cause bleeding. We don't want your ovaries to twist on themselves and on their blood supply, causing a torsion. That is usually a surgical emergency, and it's a challenging surgical emergency because
At
more
that
often than
stage,
not, yeah, I mean, more often than not, you'll lose an
big
ovary.
ovary.
Yeah, and we don't want to do that. And we don't want you to have sex, both for the vigorous movement component of it, but also because oftentimes there's still, a couple eggs in there. And the last thing that we want is for you to have sex and for you to have quintuplets. And so the likelihood of that happening is low, but it is not zero. And so that's kind of how we have you guide your activity level up until you get your next period. Once you do get your next period, you can expect it to be heavier than maybe you're used
I
to.
thought you were going to say hell.
I did too. I thought you were going to say a hell of a period.
I mean, all of those things apply because you've had all of this amazing estrogen that's building up your lining, and that lining's got to go somewhere. So it can be heavier than normal, or a hell of a period, or hellish, or any of those things. A healthy amount of blood flow. Um, but yeah, I mean, don't be shocked if it's heavier than normal.
When do we expect that period? And if I don't normally get a period, am I going to get a period that time?
You are definitely going to get a period. It may be sooner than what you expect. It can even be just within a few days because sometimes when your estrogen level starts to drop, and it will start to drop shortly after your egg retrieval, then sometimes that can make your lining be sloughed off sooner. But and it will be heavier, like Carrie said, because you have a lot thicker lining, and there's only one little teeny tiny opening in your cervix to get all that blood out. And if you have blood flowing really fast and it can't go out really fast, sometimes it becomes more clotty, and when you're passing clots, that can be really uncomfortable. So it'll be a longer, heavier period just by virtue of the fact that we've stimulated so many eggs.
How much bleeding is too much? Well, I just say I don't normally get periods often, or they're usually pretty light. Like, how do I know if I'm having too much bleeding?
So symptoms can guide this. If you are having lightheadedness, if you're really pale, sometimes you can see mucous membranes, like, your lips are probably the easiest way to check that. If all of a sudden those are really pale, if when you go from sitting to standing or laying down to sitting up or standing, you feel like the room is spinning, those kind of symptoms. If your heart rate's going really fast, if you have chest pain, if you have difficulty breathing, all of those things are things that either we need to know about or you need to go to the emergency room to get evaluated. Those are things that tell us you're losing too much blood too quickly for what your body can handle, and let's get you checked out.
Another kind of guideline is if you're using maxi pads, not like the little bitty thin ones everyone uses nowadays, but actually like a big, thick maxi pad. If you're soaking a maxi pad in an hour for 2 hours in a row, that's also a good marker.
Mhm.
Um, so when we're awaiting this period, anything else that we should be doing in those, 2 to 7 to 10 days to be getting ready for the next stage?
One thing I wanted to mention, though, and you maybe mention this in just a second, but one thing that people always worry about, and it's kind of like chicken pox for pediatricians, is it's sort of a thing of the past. We don't really see it that much anymore, but ovarian hyperstimulation syndrome. So patients still read a lot about it. The good news is most of us use a trigger with a medicine called Lupron. And for most patients, your ovaries are still going to be big and full of eggs, but the full-blown ovarian hyperstimulation syndrome involves a lot more than just big ovaries. It involves a lot of fluid in the abdomen that creates pressure in the abdomen. People can sometimes even have a liter or 2 liters of fluid. That pressure can make people vomit. And so back in the day, before we knew to do Lupron triggers, we'd have a certain percentage of patients that would get that. And so anybody that has vomiting or severe abdominal pain, we worry about that. We would bring you in, we do some blood testing, we do an ultrasound, and if push comes to shove, we can even drain some of that fluid off. Thankfully, because most of us do Lupron triggers now, and uh, typically that's a thing in the past, but people wonder about that. And I think it's more, I mean, we rarely see it anymore. And you might be mildly hyperstimulated. In fact, you are mildly hyperstimulated because you have a lot of eggs in your ovaries, but most people don't have the full blown syndrome that we used to see that required, hospitalization, that sort of thing.
Absolutely. Absolutely. Should somebody stay on their prenatal vitamins and those types of things during this time period, or do we just get to peace out for a little while?
Take them all. Keep going. Keep going with all of them. And a lot of times, if your docs put you on any other supplements like inositols or CoQ10 or things like that, a lot of times we'll tell people go ahead and keep taking them because in some cases we will need to do another retrieval and we want you to get the max benefit of those supplements. As questionable as some of them may be, if you're going to get the benefit, let's get the benefit. And they're not going to hurt you during the healing process. They don't stick around for a super long time. So if you're ready to move into transfer and it's a supplement that we're going to have you stop for transfer, that's fine too. But we usually tell people to keep on all of it, all those healthy habits that you did, the no drinking, the no smoking or other substances, all of that, the healthy diet, just keep it all going.
Good deal. Good deal. All right. So when we're going through this week, we're getting a few phone calls from our friendly embryologists. What days do we tend to get those phone calls, and what kinds of information are they sharing with us?
So in our lab, and it may be different in different labs, so there's no right or wrong answer, but generally we notify patients if they're egg freezing patients, we'll notify them that afternoon to let them know how many eggs we were able to freeze. Certainly, if not that day, the next morning, a lot of labs will notify. If you're creating embryos, we call patients the day after the egg retrieval to let them know how many fertilize. And then because we just put them back in our incubator, we really don't know anything about what's going on in the incubator because we don't want to open it up and expose them to the outside environment. So it's not until day 5 in our lab that you get a phone call. And I think actually it may be even I take this back. We may wait until day 7 until we know exactly how many embryos that we have that we biopsied. So I think it's the day after and day 7 in our lab.
So at our lab, we notify you the day after retrieval, and then day 5, 6, and 7. You get separate phone calls each day. What do you do, Carrie?
We do the day after retrieval, and then we do day 7 when we know the full count. And so I always kind of prep my patients of like, there's going to be radio silence for the majority of this week. It is the beginning of the hurry up and wait game. And so that is normal. And it's because we want to give you the full information once we have it. And sometimes if the lab says, hey, this is really going much more poorly than anticipated, let's say somebody has a ton of eggs, but there is absolutely nothing that's growing. They will sometimes give us a heads up of, hey, this isn't working, and we'll call you and kind of give you that information. But in general, we try and wait until we know the full story until we call you, because what a lot of us have found is that, and this is true with diagnostic testing, with embryos as they're coming back, all of it, is that you need the full set of information before you can give any useful advice or guidance. Because, let's say you don't have anything on day 5 and we call you and we tell you that, and you are, gearing for disaster. And then all of a sudden on day 6, you've got 4 embryos. It's as traumatic as getting information is, and as traumatic as not getting information is, sometimes it's better to just like get the information once and then react to it, as opposed to giving yourself more ups and downs on the roller coaster along the way. And so I tell some of my patients, if I could reasonably not tell you any numbers at all until we have a number of like tested blasts, I would totally do that, because usually that estimate that I give at the beginning is pretty decently correct. Where people go on these ups and downs is when they see, oh, I got 20 eggs, I'm going to get way more than the 2 embryos doc told me about. And then
the 2 embryos.
It goes down to those 1 or 2, because we kind of know what's going to happen along the way. And they feel, that they've been robbed or something's gone wrong. And in reality, it hasn't. It's just reproduction is inefficient. And so, granted, I don't do that. I keep my patients informed all the way through, but I kind of give them that heads up of, hey, these numbers are going to change a lot. That is normal. That's expected. And just, wait till we get the end, because whether you start with 2 eggs or 85 eggs, it's the number of embryos at the end that's going to make the most difference.
And so in this world where a lot of our embryos get PGT tested, so we'll know by day 7 how many embryos are cryopreserved, ideally tested. How long is the wait if you're doing PGTA, which is really looking to see if the embryos are chromosomally normal or not? What is a ballpark? We know that there's going to be some variability based on different locations, different labs, but what would be a reasonable expectation in those cases?
About 4 weeks. And, a lot of patients, when I say that, they're like, really? 4 weeks? And I'm like, okay, think about what we're doing. This is a lot of technology at work. And and more importantly, we want to make sure we do it well and we do it accurately. So it just takes a little bit of time. And literally, you'll get really detailed information like normal boy, normal girl, or if there's some other genetic abnormality, you'll know exactly what that is. So it's really detailed, science. And so it just takes a while, but about 4 weeks is pretty typical right now. May change over time, but for right now, it's about 4 weeks.
So in that time frame, we know that some doctors will do kind of some testing looking at the uterus before even starting the IVF cycle, but sometimes people do some things involving the uterus in that interim time frame. What are some things that you should probably consider having done at some point prior to getting ready for your frozen embryo transfer?
So we do hysteroscopies on pretty much everybody. We want to take a direct look at the uterus, make sure that there's not only no polyps, no fibroids, no scar tissue that's poking in there, but also no inflammation there. And we're seeing that that is really becoming a more and more valuable step. So most people during the course of their diagnostic testing have had some sort of uterine imaging, like a saline ultrasound. This is the next level up from that. And so it's taking a direct look at the lining because there are subtle changes that you can't see with the saline ultrasound, both in the form of structural abnormalities like polyps and in the form of lining abnormalities like inflammation, endometritis, things like that. And so that is probably the biggest step that we do on just about everybody, in addition to the normal things like keep taking your prenatal vitamins, make sure you're healthy. If there's any labs that we have to go back and revisit, thyroid, I'm looking at you. Those are the things that we check out in that time period.
And I would say that not every clinic is going to do everything the
Mhm.
same. Like at our clinic, we don't do hysteroscopy on everybody. We do pretty much saline ultrasound on everybody. I know in Abby's clinic, y'all do a combination of saline ultrasounds and HSGs.
Yeah.
So that is something that you're probably going to have some variability from practice to practice. Um, if somebody, what other things do we want to make sure are in check before getting ready for that embryo transfer?
Well, I think a lot of times, and I don't know about your clinics, but a lot of times things like thyroid and things like that, we try and take care of that on the front end. We also want to make sure medically you're healthy enough to get pregnant. We do things like hemoglobin A1Cs. And then for us, generally, by the time we get to the egg retrieval, we already have those things. We've already done the saline sonogram or hysteroscopy or whatever, and we're kind of ready to go at that point generally.
Any other medical conditions. So if you have blood pressure issues, if you have diabetes, if you have those things that, like we said, we try and get them nailed down before you ever start, but just doing maintenance, because sometimes it can be a while between the time that you have gone through all of that initial testing and when you actually get to transfer. And so we want to make sure that if it has been a while, especially, that everything is still in check and what we think it was, 6 months ago.
I think this is a good time for you to mention to your IVF doctor or your IVF nurse what current medications you're taking,
Yes.
to make sure that everything at this point is truly pregnancy friendly. Um, I'm a big proponent on getting on whatever medication that you're going to be on during pregnancy before your embryo transfer to
Mhm.
make sure you're stable, whether it's a seizure medication or a blood pressure medication or your diabetes medication, whatever it happens to be. There's this general feeling amongst people who are not fertility doctors that's like, oh, don't worry about it. We'll get that changed when you're actually pregnant. This isn't, I mean, obviously, this is not the situation of you're just waiting for your positive pregnancy test to see if you've missed a period when you've been having, unprotected intercourse. Like we are intentionally doing something that ideally has a 60 to 70% chance of you taking a
Right.
baby. So like we have changed the odds. So like let's be proactive. We don't want to be switching things up once you finally do get pregnant and then be
Mhm.
like, oh, well, we didn't have great control over blank disorder. Maybe that's why we had complications later on. That's just not a great way of thinking about it.
Yeah, that's a good point, Susan. If you were to get pregnant on your own accidentally and you had out of control diabetes, that's one thing. But we're actively trying to work toward pregnancy. And we know for a fact that if your diabetes is poorly controlled, we do not want to get you pregnant. Really high risk of medical complications for the baby and for you if you have uncontrolled diabetes. So we want to make sure that's in the rearview mirror before we ever get the IVF cycle started.
So another thing to think about, and this is one of those things that tends to be kind of a touchy subject with fertility patients, is you start that period after the egg retrieval and we're waiting. Sometimes we say, hey, just give us a call with your next period and we'll get ready for embryo transfer at that point. But a lot of times we offer you to get placed on birth control pills. Can we discuss a little bit why we would do something crazy like offer birth control pills and how can that actually be a strategic advantage?
So with birth control pills, especially for patients who have screwball periods that don't show up when they're supposed to, that allows us to keep a slightly tighter control. There are patients for whom they want to get started as soon as possible, and that's actually how we do it, because you get that period right after your retrieval, you start your birth control pill, and then as soon as we get your embryo results back and we know that our testing is set and ready to go, we can pull you off the pill, have you get a period, and get you started. The other thing that it can do is that, especially for some of our patients who have hormones that march to the beat of their own drummer, not to the drummer that we want them to march to, they're more prone to have cysts and they're more prone to have linings that are too thick when we want to start. And so putting them on the birth control pill helps control that, so that when you are ready to start, so is your body, and we can get going right away, rather than saying, okay, you got your period, but I'm really sorry, you've got this big cyst that's producing estrogen and it's screwing up our timing. And so we have to wait. We have to give you another medication. We have to put you on the birth control pills anyway. And so that's why we suggest that. And we promise we're not crazy. We promise we know that you don't like being on them, all of those things, but there's a reason we're offering them. It's very rare that fertility docs offer something, anything really, without having thought about it ahead of time. And so give us the benefit of the doubt, even if you've said, I hate birth control pills. There's probably a
There's a reason. Yeah.
We're bringing it up. You don't have to
Yes.
do anything, but we're bringing it up for a reason.
Right. There's usually a method to our madness. Now, a common thing that happens when people are on birth control pills is they can have spotting or light bleeding. And we want to give you the reassurance that that is okay. It is very common, especially in the first 3 months that anybody takes any type of birth control pills. You can have all kinds of side effects. And because we're usually using them for a month-ish, it's common to do that. But honestly, if you come in and your lining's nice and thin when we're about to start your treatment for your embryo transfer, that's exactly what we're wanting. And so usually we'll stop the birth control pills. You may have bleeding for another couple of days. It will stop, and then we'll start making that lining nice and plush. And we'll get into all the details of that, of what exactly is involved in an embryo transfer on another episode. But any other words of advice, things that we should kind of let people know about that's going to happen before we're doing the actual frozen embryo transfer?
I have one piece of advice just from my own experience. I would not go to work the next day. I know you're fully capable. Most of our patients are very intelligent, very smart, very get up and go and get things done. Just don't go to work the next day. There's no reason. Work's going to be fine without you, and you're just not going to feel like it. I mean, many people feel okay, but your ovaries are still really big, and I just don't think for most people, they feel great the day after. And then sometimes they'll even call and go, gosh, I'm having all these cramps today. I'm worried that something's wrong. And it's just because you've moved around so much, your ovaries can get more irritated. So, if there's any way possible, I would say take the day off after the egg retrieval.
Especially if you have a whole bunch of follicles.
Yes.
Yeah. If you got
The
one or
bigger,
two or just a couple, like under 10, that's a little bit different story. That by the time you're getting into the high teens, 20s and higher,
Yeah, you're going to be more uncomfortable that next day. It's not that you can't, it's just that you're probably going to have a little bit better day if you took a little R&R time. And remember, this is the process of you making a baby, and it takes a lot of energy. It takes a lot of oomph out of you. So treat yourself well and take care of yourself.
yeah, give yourself some TLC.
Absolutely. Absolutely. All right. Well, thank you so much to our audience. Thank you for listening, and be sure to tune in next week for more. Also, be sure to subscribe and leave us a review in Apple Podcasts. Would love to hear from you. We're on Instagram, Facebook, and YouTube. So subscribe, follow us, and stay updated on all things fertility.
And you can also visit us at fertilitydocsuncensored.com to submit questions. All questions will be answered on the podcast anonymously for our Ask the Doc segment. So leave us some episode ideas or other information. Don't hold back. We'd love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye-bye.
Bye.
Bye.